So we're going to move away a little bit now from hepatitis B. I'm going to talk to you a little bit about hepatitis C, and that's because hepatitis C care is going out into the community. Us guys in the secondary care have done what we can, basically. But so 50,000 people are thought to be infected with hepatitis C here in New Zealand. That's actually not an entirely true statistic, because since February we've had a highly effective treatment, which means that that number has dropped quite significantly. So for argument's sake, not 5,000 or 6,000 off that figure. And of the remaining people, it's estimated that only around 50% of those guys know that they are infected with hepatitis C. So that means that there are thousands and thousands of people living in New Zealand with an undiagnosed hepatitis C infection. So we've got a lot of people to find. And when I say we, I actually mean you. And that's because the World Health Organization have got some elimination targets, which the previous speakers have mentioned. And they wish to, in the world, eliminate hepatitis B and C as a public health problem. So that's actually slightly different from eradication, but it means that we need to find these people and treat them. And it would be rude to be competitive in a health industry, but on target to meet those targets in 2030 are Australia. One of 12 or 13 countries worldwide who are going to meet that target. New Zealand, not quite, but let's get there. So, chronic disease management, it's what you guys do in the community day in, day out. It's your bread and butter work. But what I'm saying is it's no more. So you guys can probably teach us many things about chronic disease management, and you probably will during the next 2 days when we're chatting with you. But what I would say to you is you probably don't manage many people out in the community with a chronic disease that you have a realistic chance of actually curing. That's quite phenomenal. And from a professional perspective, it is incredibly personally satisfying to see somebody week in, week out, for some guys year in, year out, and to be able to offer them a cure, give them some medicines, and then discharge them at the end and say, you've cured, you don't have an infection anymore. We know it's good for the patient. Of course we know it's good for the patient, but from a purely personal nursing perspective, it's pretty cool. I have to say, it's my favourite part of the job I do. And I would challenge you guys to say that Hep C is the perfect condition for nurse-led intervention, definitely. So the people that you guys will be treating in your practices and your prisons require just simply 8 weeks of medicine. It's 3 tablets once a day. 12 weeks later you test their blood and the majority of them are cured. How many chronic illnesses fall into that category? Not many. So you guys can definitely make this happen. And the reason we say that is the majority, and there are secondary care colleagues here, we've pretty much treated and discharged the people that we can have access to. The majority of adults are registered with a GP. Now, I accept that that doesn't mean that they go to the GP. Lots of people are registered and don't visit, but a lot do. They may not be going for their Hep C, but they might be going for other reasons. And what we know is that it's better and safer for our patients to be treated and seen in their community by the people that they know and trust. Much better place. For instance, travelling to the hospital. So Lauren and I may treat people that have come right from the coast all the way to see us in Tauranga Hospital. So they might do a 3-hour trip to get to our clinic appointment at 9:10 in outpatients. They then arrive with us at 9:15, hot, flushed and stressed because they've managed the traffic for 3 hours and then they've driven for an hour around the hospital car park trying to find a parking space. We then do the blood pressure and wonder why it's high. So treat these people in the community where they feel more comfortable. You guys can increase awareness and that's important. You guys are a safer place for these people. Disclosing your Hep C or talking about your Hep C when you're diagnosed, when you have to go and tell multiple people the same story, is stigmatising. It's an extra barrier to care. The less people that you have to tell that story to, it's better for the patient. And then thought I'd share this. There we go. I thought I'd share this statistic with you. So about 18 months ago, I was part of a collaboration to start a confidential clinic out at the Needle Exchange at the Mount. It's an awesome little clinic. It's fairly quiet. And something surprised me when I was working there. So once a month, Nancy and I toddle across there. I thought we would be dealing with people in the Needle Exchange that didn't go anywhere else to access any kind of care. But when I look back through the people that we actually tested for hepatitis C, those first 23 people that came through my books, only 3 of those people were not registered with a local GP. That surprised me. One of those people was local and not enrolled. The other 2 were actually from out of area, so I couldn't confirm whether they were enrolled or not. And when I say engaged, I don't just mean enrolled but never going. These people had fairly recent blood tests on the Eclair system that I could look at, so the liver function test from 18 months previous, you know. So 21 out of the 23 were engaged in primary care. These are people who are living with high risk for Hep C. These are the very people that you guys in your day-to-day business can be asking, diagnosing, treating and curing. So we can't possibly talk about blood-borne virus without touching on stigma and discrimination, and I'll start this little section of the talk with a bit of an apology, because really this should be it could be a whole day of its own, and it should certainly be a presentation of its own, but it's not. It is without doubt the biggest barrier to care that people living with Hep C have. And there are some definitions from the English Oxford Dictionary. I won't read them to you, you can read for yourselves. Now, back a few years ago when I started working in hepatitis care and HIV, yes, the stigma is there too, I was of the firm belief that stigma and that discrimination happens out there. It doesn't happen here. You know, it's those people that are not educated, those people that don't go to nursing school, those people that don't come to these training days. But in actual fact, when you look at the research and you talk to the people that live with blood-borne virus, we are the worst perpetrators of stigma and discrimination, which is heartbreaking. And it is a barrier to care. So I ask that you should really seriously consider the words that you say, the thoughts that you have, question them, and stand up and be counted for this group of people. So the effects of stigma and discrimination are far-reaching. So they don't just stop people perhaps being honest about a risk factor, but they also have negative impacts on the life that that person leads. So they have a lack of self-worth. That can spiral and result in many negative things. That can then result in social exclusion, loss of work, loss of housing, difficulty finding accommodation, all of those kind of things. And then you get into a negative circle where that climate of fear prevents people from seeking care, about being open and honest about risk factors, and about avoiding healthcare. And that allows a continued spread of hepatitis C. Be mindful of your words and mindful of your actions. They're very powerful. So Lauren and I are nurses. We're coming at this from a nursing perspective. These are actual quotes from some patients of ours. So I've not just made these up for this presentation. This is some of the things that people have said to me in clinic. I feel dirty. Just for a minute, put yourself into that person's shoes. Can you imagine day in, day out, feeling dirty because of a health condition that you've got? And then I had a guy who unsuccessfully tried to treat his Hep C years ago with the much more arduous treatments, who didn't clear the virus and was coming back to clinic. And he said to me, I can physically feel my skin crawling because I know that virus is back in my blood. And that for him was a huge issue. And then the third thing, I guess probably all of us have heard this said. I've heard it being said multiple times. And sadly, I've heard health practitioners say it in reverse I know it's my own fault I have this, but imagine living with a virus that you feel guilty about because you believe that it's your own fault you have this. And then an out-and-out example of discrimination. My dentist puts me at the end of the list each time I visit for safety. In no way, shape or form is that ever acceptable, and I would just say as a nurse advocate for that patient, let's stand up and be counted and remove some of this stigma and discrimination. Oh, there we go, a bit fancy. So in order to diagnose patients, we have to be able to identify the risk factors for people living with Hep C, because we are not advocating blanket testing. We might like to, but we're not advocating it. We are risk testing. So that means you have to know what the actual risks are for contracting hepatitis C. And people living with Hep C don't look a certain way. You won't know. You know, these people that I tested in needle exchange had been into GP practice. They didn't have big flags saying I'm a needle user. You know, challenge the stereotypes. However, we can't get away from the fact that needle use is, in New Zealand, the largest cause of hepatitis C. And I would just add in there, not just your traditional needle use that people most think of. A large amount of people use needles for appearance and performance enhancing drugs. Bear that in mind when you're seeing people, and that is something that also surprised me in needle exchange. And then, ever received a tattoo or body piercing, but that's from unsterile equipment, so not your person who's been down to the tattoo parlour and got a proper tattoo, you know, in a professional manner. Blood transfusion before we were checking the blood in New Zealand, or ever had any medical treatment in the high-risk countries. Bless you. And then anyone that's ever been in prison, so some of you guys, some of our colleagues here are prison nurses, I would say you guys don't need to memorise this risk factor list. Your guys are looking at people who've got a risk factor instantly, so bring it into your everyday language. Can we test you for Hep C? Normalise it. And then we have to add in the vertical transmission, which is similar to hepatitis B that Dr. Moyes talked about earlier. The quoted risk factor in the research for mum-to-baby transmission of Hep C is around about 5%. So it's a small risk, but it's something that we shouldn't forget about. Now we accept, we've been doing this job a while, so difficult conversations are part and parcel of what we do. We're also HIV nurses, so it's, you know, we meet somebody and know the most intimate of things straight away. So we realise that having difficult conversations is tricky, and for some of you guys it'll be new to ask about those risk factors. And from a nursing perspective, if you just use open, honest and to the point language, you will probably find that it is only difficult for you, not the person you're asking, if you do it in an open way. Start the conversation by saying, I'm sorry, this is a difficult question and we've only just met, but I'm going to ask you anyway. You know, come from a place of no judgment. Because we can only offer testing and treatment if we can identify risk behaviour. And what I will say from a personal perspective, it definitely gets easier the more you do it, absolutely. And I would challenge you to build in that Hep C screening into every task that you do with a person. People will only disclose risk activity if they feel safe to do so. So Joe Bloggs might have been for his sutures removing earlier in the year and said, no, I don't have any risk factors. But 6 months down the line, if you ask again, he might feel that it's actually a safe environment to disclose something to you that he didn't feel comfortable disclosing 6 months ago. So ask, and then ask again. That's okay. If you're asking everybody, you're not signalling, you're not singling even anybody out. And I'm going to pass over to my colleague now. Thank you.
So looking at offering initial Hep C testing, we've got to start somewhere. So we need to start the conversation. Every opportunity, as Nicola said, is a good time to ask any adult coming into your practice. For example, vaccinations, dressings, smear taking, BP monitoring, diabetic reviews, you name it, I'm sure you could do it. You could start by just popping the conversation in, saying, have you ever been tested for Hep C? Or have you heard or are you aware of the fact that there's free treatment for hepatitis C? Once you've got past that initial conversation, advise the patients who are interested that you need to be testing for a few other tests. We test for hepatitis B past or present, and that's very important because reactivation of hepatitis B could be possible during or after treatment. We also test for HIV as one of the treatment medications. Atazanavir is contraindicated with Mabbutt, and also because it's good practice to be testing for that at the same time. A few other points to consider possibly is if you have a female patient who's interested and concerned she may be pregnant, add that to your testing. Mabbutt is not recommended if pregnancy is planned and there's no data and not known during breastfeeding, correct? The other question you might want to ask is, has the patient ever been treated before? Or have they ever had a liver transplant? And let the patient know that if we do an antibody test, further testing may be required after that. Feel free to jump in with any questions along the way if you need to. So your antibody test comes back positive. Where to from here? So 25% approximately of people spontaneously will clear hepatitis C, which is why we go on to test for a viral load. Are the positive antibodies due to a previously cleared infection, or is this a chronic infection? Antibodies can also take up to 6 months to develop. So if there's any risk of it being a new infection, you might need a delayed test or a repeat test down the line just to check. It could be helpful to write antibody positive on your lab form if you're sending that off. Sometimes the lab will query if you just request a viral load. And viral loads generally can take from a few days to a few weeks to come back, depending on whether your local lab batch test or whether they run it. We're quite fortunate in Tauranga in that Bay of Plenty tests are run at our hospital lab, and they generally come back within 2 working days, which minimises anxiety levels for some of your patients. Viral loads generally come back and reported as not detected, or they will come back in a number of copies per mil, as with the B, or in log form. So your viral load comes back positive. A couple of things we need to do. We need to stage the liver damage to see where this patient is at on their liver damage history. So on your local electronic pathway, we tend to use the Bay Navigator in the Bay of Plenty. There's a step-by-step process on how to request FibroScans, along with heaps of other very, very helpful information. It's really good if you've got a recent full blood count and a liver function test on hand, because you're going to be wanting to run an APRI score, which is an AST to platelet ratio index. So that's a tool that can determine the likelihood of liver fibrosis or cirrhosis, and it's available on that MD Calc site that people were talking about. Very, very easy. Put your 2 numbers in, it gives you a result. If your APRI score comes back as greater than 1, you're going to want to have that and your FibroScan and send the whole package off, probably for secondary care input. If your FibroScan comes back over 12.5, we're going to be looking at cirrhosis. You're going to want to move them on. So if your patient comes back as the tests indicate that they're cirrhotic, they've previously failed any hepatitis treatment, they're co-infected with hepatitis B or HIV, refer them on to secondary care. If you're unsure on any of those points, ask your local hepatitis nurse. There are lots of people who'd be willing to answer that. But your treatment cohort, aside from all this information, are the uncomplicated, easy to manage, easy to treat. So a couple of nursing considerations that Nicola and I were thinking about what we do in our practice. So things to consider from a specifically nursing perspective is that patients may only remember a very small portion of what you tell them at that initial meeting. We like to offer a face-to-face meeting to discuss if it's a new infection. They're likely to have multiple questions around treatment and things like disclosure. And please remember to be sensitive and aware of the patient's right to confidentiality. They may not wish their nearest and dearest in the community knowing or being part of that treatment process. So busting a couple of myths, things like hand holding, hugging, kissing, hongies, they're all good. Cutlery, crockery, sharing a meal or bedding are all okay too. And reassure your patients that coughs, colds and sneezes are not going to transmit the virus either. Low-risk items that may come into contact with blood products should not be shared in the same household. So that includes toothbrushes, razors, nail clippers perhaps. Sexual contact is low risk if there's no blood contact, but it's slightly higher risk in men who have sex with men, people who have multiple sexual partners, and sex workers. And I have the data to back that if anybody would like it. And for nursing staff, just an FYI, with hepatitis C, needle stick injury is only around a 3% transmission rate. If you have a mother who asks you about the potential for vertical transmission and passing it on to her baby, babies can be tested after about 18 months because of maternal antibodies, and the incidence on vertical transmission is around 5 to 6%, sorry, in non-HIV infected mothers, and it rises to around 15% in HIV positive mothers. Run through your high risks again, other practices that they may not be, have thought about at the time. Follow up your conversation, your face-to-face conversation with written resources. There's some really good stuff online, Northern Regional Alliance brochure, multiple information sources which we'll offer at the end too. It's also a good opportunity at that face-to-face meeting to see if other services may be of value to your patient, like community psychiatric support, where the nearest needle exchange is, if they are using needles and not sure where to go, if the patient would like to be referred to the addiction services, for example. We like to go through the brochure page by page with the patient and fill in our details at the back of the brochure. Who do they contact? Who's going to be their pharmacy? Things they can go back home and look at if they wish to. If they're not planning on sharing their information or having a support network at home, show them where to find it online. And in some small centres, something I was thinking about is that we've had a number of patients who've preferred not to use a local pharmacy for their supply. They're in small centres, they're known well, possibly related. Family members may work there. They may choose to go out of town to an approved pharmacy rather than go to their local one. Something to ask them. I am not going to go through too much detail on preparation for treatment with Mabbutt because I know Dave's going to be running through that in quite a lot of detail. So that's can I leave it at that, Dave? Are you happy? You'll be doing the rest of it? So is this actually extra work for us as nurses? We're not sure it is. Get creative. Take it on to the end of what you would normally be doing, as Nick said earlier. Have your resources handy in your nursing stations for anybody to be able to access. Laminated high risk factors. I'm sure you could come up with a load more. Anybody want to add anything else onto that? Extra work? Yeah? No? No? So from our perspective, pretty much all pros, no cons. As Nick said, hugely satisfying. From our experience, there's a very small initial effort doing that workup. And then there's literally no follow-up required unless the patient contacts you or needs a little bit of extra support. 12 weeks after treatment, you're going to be popping out a lab form in the mail or faxing it to the local lab for them to test their viral load to see if they've had a cure. And then you can follow it up with a face-to-face meeting if you wish, or if the patient wishes, a phone call to say, yay, cured. So remembering that untreated hepatitis C, on top of other lifestyle factors, for example, alcohol, can speed progression to liver cirrhosis. Alex has already mentioned, with Hep B, what we're looking at with, liver cirrhosis and where that can go. So 20 to 30% of patients with long-term hepatitis C virus develop cirrhosis within 20 to 30 years of infection. Bearing in mind that liver cirrhosis is a well-established risk factor for hepatocellular carcinoma. So 2 to 4% of patients per annum, Alex reminded me, with liver cirrhosis develop liver cancer. And also remembering that 90% of people with liver cancer have underlying cirrhosis. So, how do we find these people? We need to work together. We all need to get involved to find this missing 1.1% assumed infected in the general population. So if you think that for every one person that you are seeing, every one person in 100 that you are seeing in your practice, that one person will have Hep C. So looking at it really, despite the volume of extra information you've been given, it all boils down basically to 5 steps. Identify your at-risk patient, diagnose through your lab tests, stage their liver, look for drug-drug interactions, and that you're going to cover on the Liverpool website. Beautiful tool to use there. While you're looking at drug-drug interactions, prep the script, have your drug interactions ready, pop it under your prescriber's nose and say, please sign here. Go ahead and treat. That's what we do, don't we? We do that, and it works. 12 weeks, test for your cure. So do your homework, and after that, all good. So, no sound effects, I'm sorry, but that is woo! So, 12 people, that's 12 people, as Nick said, who no longer feel dirty. 12 people who no longer put off going to the dentist or worry about being last on the list. Or, as somebody mentioned to me the other day, facing someone wearing hazmat protection. That's 2 people who are not going to go on and develop liver cirrhosis. And maybe someone who's now not going to develop liver cancer. Hep C treatment works. Let's do it. Join me, that's all right. We can bellow. So Nicola and I share that mobile number. We both work part-time in the role, and we have an email address that, for even if you're not local, I'm sure we can help point you in the direction of somebody in the area if you have any questions. We're absolutely happy to get involved. A couple of extra supports online. AbbVie have actually got some fantastic information on there, so good one to go on.